Yeah, by 6 to 8 weeks, absolutely normal, and probably even much shorter than a young, healthy, otherwise person. So here now we are a couple months later, he still has an abnormal chest X-ray. That's something wrong. Okay, and we also then see evidence on the other side that there's something wrong. Okay, so let's continue. Okay, what study do you think would be most helpful for you to this patient? Would you say, given these X-ray changes, what you perceive to be bronchiectasis, get a routine culture and sensitivity on the sputum? Would you say, he's got, looks like maybe a nodule in a CT, let's get a serum ankle level? Would you say, I spelled eosinophil wrong, excuse me, I did this last night. Eosinophil count, blood eosinophil count? Or would you think a serum IgE level would be the best approach? Anybody want to do a routine sputum culture?
No, not sure.
It could be helpful, especially if you're concerned about maybe pseudomonas and you're thinking about bronchiectasis, cystic fibrosis. Does this look like cystic fibrosis and bronchiectasis? So it's not the wrong answer, but it's not the best answer. An ankle level? Maybe it certainly wouldn't be the best answer. If he does it a nodule and so forth, I don't buy that. Blood eosinophil count? Well, he's got asthma. It's going to be high. Maybe if it were 25,000 or something, you'd be concerned and think about a hypereosinophil syndrome, but it's not going to be that specific. How about a serum IgE? Sure. Now, we talked about IgE levels two times ago. And what do we say most asthmatic see at the level of what? 2, 4, 6, 800, in that hundreds range. We saw an IgE level in the thousands range. The differential diagnosis is totally different. So this one blood test can really put us over here or put us over here. Okay? And I think that would be my choice. If you were in an exam and they were asking you for choices, this would be very, very helpful because the differential diagnosis of hypereosinophilic, IgE level. Now, you could argue the same thing with a blood eosinophil count, but it would not be as specific. So now let's go on. Sure enough, he has an IgE level of 2,814. He has a total of 1,000 eosinophils in his peripheral blood. Serum precipitants are positive for Aspergillus. Skin testing is positive for Aspergillus. ANA and rheumatoid factor are negative. RAS testing is positive for dust mite. RAS, remember the radiology sorbent testing for specific aeroallergens, the so-called RAS testing, was positive, which tells us that he's atopic, and we certainly know that from his IgE level. Alpha-1 antitrypsin normal. CF gene testing was normal. ACE level was done, I'm not so sure why. And his PFTs show what? Mild obstructive lung disease. Okay? DLCO normal. Breathing capacity normal. Okay? So, diagnosis? Allergic bronchial rhamnosis. So here's this next complication. Was made. Started on a course of prednisone. Patient approved, was weaned off the prednisone. 2 years later, he complained of shortness of breath, cough, night sweats, lethargy, loss of appetite, weight loss. On exam, he's wheezing again. He's hypoxemic, and O2 sats low. Here's his chest X-ray. What do you think these infiltrates are? If you look under the microscope. No, it's not a granulomas. This is not a type 4 hypersensitivity reaction. Type 1.
Is he having an Aspergillus?
Well, an aspergilloma is usually in a fungus ball that's in a cavity. And we don't see cavitation. Well, the answer is the following. This eosinophilic pneumonia, which is what you get with Aspergillus. It's an allergic pneumonia. We just see the same thing as we saw before, just a different mechanism, a different provocateur. And this long, kind of a funny looking shape, isn't it? You don't look at pneumonia and say, that's pneumonia. It's probably just some atelectasis, maybe mucus plugging. This sort of looks, not the way it would look like, a squashed in lung like that. Okay? This is what his CAT scan looked like at that point. Again, large area consolidation there. Maybe some more consolidation here. See what else you can see. Maybe a little bit more of that central bronchiectasis there. Maybe some here and here. But that's what we're looking at there, consolidation. At this point, he's begun on voriconazole. Bronchoscopy, inspissated mucus left upper lobe. Transbronchial biopsy showed pulmonary fibrosis. BAL showed a lot of eosinophils. Again, sorry, I cut that off. Sputoculture negative, TB negative, IgE level at this point was 3,000. So the diagnosis obviously was allergic bronchiopulmonary aspergillosis. Here's what a follow-up scan. Look at all this again, this central bronchiectasis. You see it there? Again, not out here as much as more central, maybe a little bit of it there, maybe some of it over here. And that's what the central bronchiectasis looks like. So these are some of the X-ray findings of allergic bronchiopulmonary aspergillosis. The tram-line shadows of thick bronchial walls, parallel lines, ectatic bronchi, ring shadows that I showed you before. That was a big ring around the small vessel. Toothpaste shadows, which are mucoid impactions. I think I also showed you that Y was a mucoid impaction there. And then glove and finger shadows, the same thing, intrabronchial exudates and mucus plugging. So this is the findings. So pathogenesis, normally there are low levels of IgG against fungal antigens in the circulation, normals and asthmatics. Low antifungal secretory IgA, but an exposure of atopic individuals to fungal spores or the mycelial fragments, you get an IgE response and an IgE both. And that's where you get the serum precipitants positive for Aspergillus, or IgG. You get high IgE levels to the Aspergillus organism with a concomitant CD4 response, some response. They generate cytokines, these T cells which potentiate interleukin 4, 5, and 13. And then some of the proteolytic enzymes and mycotoxins from the fungus cause even some neutrophil infiltration. So these are the major diagnostic features of classic ABPA. History of asthma, almost always there's a history of asthma. Intermediate skin tests are positive for Aspergillus, that's the type 1 reaction. Precipitating antibodies to Aspergillus, positive, that's the type 3 reaction. Total serum concentration greater than 1,000, that's why you always check an IgE. If that IgE is off the wall, this is the diagnosis to think about. Peripheral blood eosinophilia, I mentioned the lung infiltrates. I showed you the central bronchiectasis, which now you know what it looks like, and elevated specific IgE and IgG to A fumigatus. So there are actually different classes of Aspergillus, which are probably, I don't think, all that important, but just for completeness, I thought I'd mention them. History of asthma, skin test positivity, IgE levels greater than 1,000, central bronchiectasis, and then these specific serum antigens. Minimal essential criteria to diagnosis, something that's called allergic bronchiopulmonary aspergillosis, CB, central bronchiectasis, with central bronchiectasis, but you can also have it without central bronchiectasis, the same diagnosis. And this is just sort of the stages. So since time is short, I want to get one more question in, and let's talk about this guy. Another asthmatic. He comes in for his routine yearly examination. He has some mild exertional dyspnea that's long-standing. He's got chronic cough, absolutely unchanged. He's had no recent history of asthma exacerbations. He's on an inhaled corticosteroid LABA. His FEV1 and FVC percent are both somewhat reduced. So he's got chronic airway remodeling. We talked about airway remodeling in asthma, long-standing asthma, low lung function, despite the fact that he hasn't had any recent asthma attacks. but he does have shortness of breath on exertion because he's got airflow obstruction. Okay. Now, we're doing the exam, everything is fine. Maybe you hear a little bit of an expiratory wheeze, and he exhales forcefully. And you're almost finished the exam, and you happen to look down, and you find this abnormality on your exam. Okay, everything's all right? Now comes the question. Okay, so with this abnormality and the history of his asthma and airflow obstruction and dyspnea and cough, which of the following answers is correct? A, the patient likely has COPD. Just because you walked in a minute late, you're doing an exam on an asthmatic, and you see this. Oops, sorry, okay, you see this. Okay, and this is the question. The patient likely has COPD. Well, he's been a non-smoker all his life. He's got airway obstruction, but he doesn't have COPD. And now he has this abnormality, which I heard rumbling that people think he's got clubbing. Clubbing with COPD? Never. Out of the ballpark. Not even close. You see a COPD patient comes in with clubbing. It's not COPD. The physical finding can be seen with asthma if long-standing associated with fixed airflow obstruction. No way. An asthmatic, long-standing, non-smoker comes in, not asthma. ABPA is likely with central bronchiectasis. Bronchiectasis, you see clubbing? Yeah. Yeah, you do see clubbing, but not with allergic bronchial Aspergillus usually with the peripheral kind of clubbing. It's not very common. Bronchogenic carcinoma is a more likely cause. Oh yeah. Even in a non-smoker, unfortunately, yeah. See a certain percentage of non-smokers. Okay. So, let's talk a little bit about clubbing. You know that it's an increase in the longitude and transverse curvature of the nail. Okay? The hallmarks of clubbing are softening and periungular erythema of the nail beds, which causes the nail to seem to float rather than being firmly attached. Now, we're going to examine each other's nails in a minute and just sort of make sure you know. And the reason I actually thought about asking this question and presenting this topic is because I was recently with a pulmonary fellow who came around the bedside and said, oh, this guy's got clubbing. And I asked the question, what is the best physical finding of clubbing? What's the most reliable physical finding of clubbing? And this fellow didn't know, so I'm assuming that maybe one of you doesn't know. So I presented maybe some of you don't know. So there's an increase in the normal 165-degree angle that the nail makes with the cuticle, and enlargement or bulging of the distal phalanx, which becomes warm and erythematous. I'll show you examples of this. And a curvature of the nail themselves. Okay? So, I thought this was a question, but I didn't ask it. Here is what this looks like. Okay? On the left, we got a normal nail, a normal hand. All right? Look at the angle. Now, you have to read this carefully. The cuticle angle appears to be an angle with the. Let me read it to you. Okay. There is a softening of the periungular erythema of the nail, which causes the nail to seem to float. I'll show you that in a second. Increase in the normal angle that the nail makes with its cuticle. Okay? So, in other words, the angle that the nail makes with its cuticle is this angle right here. Okay? And this, if you look here, okay, this is at least, usually it's 180 degrees, maybe a little less than 180 degrees, and this angle is becoming closed in. Okay? So looking at, this is the most sensitive way of doing it. So looking at your own thumb, okay, the first thing is, at the base of the nail, you push it in. With you and I, you push. It feels kind of firm, okay? Patients with clubbing, you push it in. Not only is it a little bit enlarged or full, but it feels kind of spongy. It's like a sponge. You push it in, and it's soft and spongy, and it gives. But right along here. But the best finding is this right here. You look here at this angle, okay, where you can see that the angle becomes less and less. So in other words, here's 180 degrees almost, right? This angle right there, okay? And from there to there, all right? And look at this angle here. See it? So it's closing in. In other words, if this is more club and more club, this angle would be less and less and less and close in. Okay? Then the next thing they talk about is the width here from here to here. Very often it's splayed like this. Okay? So that you get a larger avulsion of the distal phalanx, which actually may even be warm enough. They're talking about the lateral portion of it. And then curvature of the nail itself, which is the least reliable, is sometimes actually on this guy here. This here, look at this curvature. Okay, that's the least reliable of all. You can see this with other conditions. But look at the company that it keeps. Look at this angle here. Again, less than 180 degrees. The curvature here, the sponginess over here. This is where you push in, get the sponginess, and then laterally. The difficulty. So the most reliable finding is this angle. The distal region of the digit appears swollen because of hypertrophy of the soft tissue around the nail. This angle, I didn't know until I looked it up, called the Lovabond angle, formed by the nail plate emerging from the proximal nail fold and the dorsal distal phalanx. In clubbing is greater than 180 degrees, which is usually less than 180 degrees, which we just talked about. Now, you can't possibly memorize all the causes of clubbing because there's just so many. And I'm going to show you, when we talk about pathogenesis in a second, it becomes kind of obvious of what would be and what wouldn't be causing a clubbing. But there is a hereditary form of clubbing I'll talk about in a second, called pachydermal periostosis. Obviously, lung cancer, fibrous tumors, pleural, benign pleural tumors, malignant pleural tumors, other thoracic neoplasms, SBE, certain infections like an infected aortic graft. Look at some of the weird things, the Seth's, Takayasu's, arteritis. It just goes on and on and on. Liver disease, certainly cystic fibrosis, abscess, empyema, and so forth. The list is biliary cirrhosis. The list is extremely long. There's something unilateral clubbing that's usually associated with vascular disorders like aneurysms, AV fistulas, and so forth. Now, here's the important part of clubbing that I think only recently has been understood because we have a much better understanding about cytokines and chemokines and other inflammatory mediators. Okay, so remember that the main pathologic finding in clubbing is this increased capillary density. That's what you're feeling here when you push in. That's why the nail bed gets very wide. And that's why sometimes it's even warm. The nail is warmer than it should be. The most potent stimulus is new capillary growth is hypoxia. So if you have an hypoxic area, you get new capillary growth. Hypoxia causes an intense production of vascular growth factors such as VEGF, vascular endothelial growth factor. So it's understandable why in hypoxic situations you can see clubbing. Histochemical staining shows increases in this VEGF, but also other mediators, platelet-derived growth factor, hypoxia-induced growth factor, and HIF, another growth factor, with increased microvessel density in the stroma of the club digits. So for decades and decades, and 100 years, nobody understood why there was clubbing. And now we understand it's these vascular growth factors that produce these excessive capillaries that then produce this excessive tissue and the sponginess that we talked about. Now, the second common characteristic of patients with clubbing is shunting the blood past the capillary bed, either in the lung or the liver. That's why you see it in liver disease and why you see it in lung disease. So, for example, you can have something called hereditary hemorrhagic telangiectasia, which is a disease that mostly shows up from in the gut with GI bleeding, shows up on the skin with telangiectasias, shows up in the brain with stroke and hemorrhagic stroke, or shows up in the lung as something we call AV malformation, hemorrhagic, hereditary hemorrhagic telangiectasia. These lesions in the lung are actually shunts that go through the lung. They're little AV malformations. And blood is shunted away, and one of the hallmarks is hypoxemia. Hypoxemia is worse with exercise. Why would it be worse with exercise? If you're low VO2 and put you on a treadmill and you have AV malformations in your lungs, why does it get worse with exercise? What happens to your heart rate? Stroke, why? Your cardiac output. What happens to the blood as it goes through this AV malformation? Increases. So essentially you're increasing the shunt by increasing cardiac output. It's that simple. Increase the amount of shunted blood. So these AV malformations in the lungs are exactly what this is talking about. That there is actually shunting of blood away from capillaries. Now, this suggests a lack of metabolism of these angiogenic factors that bypass a critical organ, lung, liver, and may be involved. Several of the conditions associated with clubbing have inflammation or shunting, such as bronchiectasis and liver cirrhosis. So this is why people get clubbing with these diverse, I mean, you say to yourself, what does the liver have to do with AV malformations of the lung? And there's the answer why, and why people get the clubbing. So, this is just a summary. So the prevalence of clubbing is found in about 1% of all admissions that you're going to get. So you're going to see clubbing, look for it. It's associated with serious disease in about 40% of the time. New onset clubbing always warrants a chest radiograph, and if no abnormality is found, get a CT. New onset clubbing is not a normal thing. Even if the patient may have maybe inflammatory bowel disease or some other kind of cause over there. New onset clubbing, think about obviously cancer. And obviously the neoplasm may be still localized and curable. One of the striking features of clubbing is the speed with which it can develop, in about 2 weeks in patients with new onset empyema, and with it can reverse also about 2 weeks in patients with corrective cardiac surgery.